My name is Mercy Shabamo. I am with the Eswatini Hospice at Home Hub team. Thank you for joining us once again for our ICA session. Can you kindly introduce yourselves? But I'd like to start with my team this side and then Thandazile. Please then introduce yourself and your team members.
Good afternoon, team. My name is Nonverbal. I am at Hospice at Home. Good afternoon. My name is Eswatini. Thank you.
Good afternoon, team. I'm here at Hospice at Home.
Afternoon, team. I'm Sunday Master. Eswatini Hospice.
Thandazile, please introduce yourself and your team members.
Hello, I'm Eswatini with Xolile Dube from Manzini Government Hospital. Thank you.
Thank you, Amy and Xolile. Welcome to our ICA session. I can see Thandazile is still okay. Or Zinhle is still joining. Zinhle, can you hear us? Please introduce yourself and your team members. Zinhle, please introduce yourselves. Zinhle, are you able to hear us? In the interest of time, can we continue with our introductions in the chat box, where we can write our name, email address, profession, and facility that you are joining from. Today, we are going to be looking at pain assessment for nonverbal and cognitively impaired patients. But just to quickly go through what we looked at in our previous session, we were looking at the quantitative pain assessment because we are still treating the pain assessment series. So when we're looking at quantitative pain assessment, we looked at the pain intensity assessment scale and the pain assessment tools. And when looking at the pain assessment scales, we looked at 4 pain intensity scales, which are commonly used. And if you missed out on that session, you can join or you can log into our YouTube channel, which is Eswatini Hospice at Home YouTube channel. And you can be able to catch all the other sessions that we've had previously. You can even subscribe and click the notification bell so that you can be able to be notified whenever we are posting any content or sessions that we've conducted. So still on the quantitative pain assessment, we looked at that although pain is subjective and it is self-reported experience of the patient, the ability to quantify the intensity of pain is essential to monitoring a patient, the patient's responsiveness to analgesia. We also had a case from RFM Hospital, from the RFM Palliative Care team, where they presented about a 48-year-old female patient who was diagnosed with chronic venous ulcer. The main problem was the poor prognosis of the patient's condition. And the chief complaint from the patient was a non-healing ulcer above the ankle since 2016. And then from the assessment conducted by the palliative care team at RFM, they concluded that the patient was clinically stable, fully aware and well-oriented, and that on her left ankle, The dressing was wet and there was an unpleasant odor. And then for a further plan on that case, the further plan was cleaning the wound with salt solution and dressing it with adaptic and Inadin on alternative days. And then another plan was to educate the client on the importance of proper diet. And then the recommendations from the HUB team was that a continuous assessment on psychosocial and spiritual needs should be conducted so that the client can receive holistic care. So please remember to introduce yourselves in chat box, as we have mentioned, your name, your profession, your facility, and your email address. At this point in time, I will hand over to Mr. Mahlangu, who will give us a presentation on pain assessment for non-verbal and cognitively impaired patients.
Thank you, colleagues. Today we are wrapping up our presentation on pain assessment. So this is our last presentation on pain assessment. Then from this session, our coming sessions will cover pain management, and we will be looking at pharmacological first, then we go to pain management in terms of non-pharmacologic. So what we are going to do is that today we will be wrapping up our session. So we will be looking around on how best we can combine both the qualitative and the quantitative skills of pain assessment into persons who cannot verbally communicate. If you will note the previous session, we were looking at how best we can assess a patient who is able to talk or who is able to relate with us. But then we understand that that's not the final goal. That's not only the people we see every day. So we'll cover the introduction, then we'll look at the framework for the non-verbal and cognitive patient, and then we'll look at the pain behaviors in a non-verbal cognitive impaired patient, and then we also look at assessment and treatment in non-verbal patient, how best we can do it. We will also look at relevant instruments, implications for pain. Then we look at the overall on what are the key points on total pain assessment. Remember, when we started, we introduced total pain assessment. We started with total pain, then total pain assessment. So we'll be wrapping up all that today. So what we can understand is that there are many barriers that we face in palliative care assessment for the non-verbal, but the issue of being non-verbal and cognitive is the major barrier. So it is the very problem that sometimes makes us to omit pain assessment. And then we also understand that inability to communicate effectively due to impaired sensory loss does not refute the possibility that an individual is experiencing pain, and it needs an appropriate pain treatment and or relief need. So we need to do it. The fact that it is also a serious problem for many patients with life-limiting and threatening illnesses. So this is a real problem. And we need to know that when we have these patients who are unable to communicate verbally effectively, it increases the potential for them to experience unrecognized and unrelieved pain. So they are always at risk of suffering pain. So therefore, the observation of behaviors or surrogate reporting must be utilized in persons who cannot talk. So we rely most of the time on the people, the surrogates, or the people who are taking care of these patients. So for them to tell us what is happening, and we need to educate those people on how best they can assess a patient pain. So there's a framework maybe that we need to understand when you are going to approach a patient who's unable to communicate verbally and who is cognitively impaired. There's a framework that you need to take into consideration in such patients. The first thing that we need to understand is that we need to use the hierarchy of pain assessment techniques. That is, get self-report, if possible, in all the ways. In the previous session, we were talking about how best you can engage on communication with patients. One of the things we've emphasized when we're looking at the principles of communication, we were saying that even if the patient cannot talk, but meta communication and some body language is very important. So you need to establish another way of communicating with your patient. So get the self-report. Another thing that we need to do is that you search for the potential cause of pain or other pathologies that could cause the pain. So the patient can report, then you also do the examination. You do the holistic assessment on anything that can be of potential cause or other pathology that could cause pain. For example, a patient with advanced stage cancer, we know definitely there is pain. We may never know the severity, but we will know there is pain here. The other thing in the hierarchy is that you observe the patient behaviors. Last session, Mr. Kele presented on a flag scale, which is one of the scales we use, and you also introduce us to Wonga faces and different tools that can help us. But here we are saying the most relevant one is the flag scale. So you observe the patient behavior that is indicative of pain, you know, frowning, squeezing, or doing all those things. So we look at then another thing that you do after we've observed any signs of behaviors of that, you also obtain the proxy reporting. That's why with these people with cognitive failure, with dementia, old age, you know, unconscious patients, sometimes it's very important to see that you obtain the proxy information from the proxy carer, which is the family member, the parents or caregivers, about the pain or any activity changes, you know, because they know how the patient has been behaving. So any activity changes, they will show, maybe they'll say when I'm moving the patient, this is how the patient behaves. And then lastly, on the hierarchy, you need to attempt an analgesic trial to assess a reduction, if possible, in pain behavior. You know, a patient, you will discover that in reality, you cannot tell at what level of pain is the patient experiencing. So sometimes then you will begin to take the analgesic trial. Maybe you start with the step one. If they're not responsive, you repeat, you add step two until the patient, the behaviors are changed. And then you establish a procedure for pain assessment. You know, this is very key. Not every patient will use the same strategy. Different patients with non-verbal and cognitive impairments, you need to have different procedures you're going to use. Use behavioral pain assessment tools as appropriate, especially the flag scale or the adult pain assessment tool for non-verbal. Minimize emphasis on physiological indicators. You know, the fact that the skin is reddish, is sweating, you know, minimize the emphasis on those things because they may not be indicative of pain, but they can also be indicative. So then you do your reassessment and documentation. So this is the framework that we need to build in our assessment. Then we'll be able to assess this patient. I'll just brush through this. I will not read everything here, but I will just draw your attention on the behavior that are there in patients with non-verbal who are indicating that this patient might be having pain. So you need to look at these behaviors. First of all, the facial expression. It is abnormal for a person to be always frowning, even if it's your colleague at work. If he's always frowning, it means there's a problem. There might be physiological, psychological, spiritual, emotional pain. So not normal. So look at the facial expression. You cannot fake it. So you look at the face. How is the face? How is the frowning? Eh? You look at the wrinkles, in the face. So you look at those things. Sometimes they clench the jaw, especially the elderly one. They will be clenching their jaws, Some will have rapid blinking from all of a sudden. Body movements, reckless agitating, doing all those things. Intermittent shifting of position. Now it's changing this side, now it's changing this side. You take constant of those things, body movement. Protective mechanisms, you will find that they are holding the area that is so painful. Sometimes they are splinting, they are clutching, sometimes they are massaging that area, they're trying to protect themselves or deal with that pain. Sometimes they are verbalizing. They will be saying something, sometimes they will be saying in common places, sometimes they will say, help me. Sometimes they will be so angry, get away from me, don't touch me here. They will be cursing, they will become abusive. Sometimes the caregivers will say she doesn't want us to come closer to him, and she's like this. They don't understand that that's how he is or she is expressing pain. And then other things that they use their vocals. They will be screaming. You will feel that the person is mourning, the others are groaning. Men, don't cry. You'll find that the man is groaning. Sometimes they will be crying. They will say all sounds that it depicts that there is pain in that patient. And then sometimes pain comes with mental status change. All of a sudden, they become confused, disoriented, irritability, depression, and distress. So such things, they are indicative of pain in the patient. And then also you look at changes in activity patterns, routines, and interpersonal interactions. The patient now has begun to stop eating, now does not want to sleep. They don't want to participate in social activities. If in this house you were watching TV together, sometimes they don't know now to go for TV. They change in ambulation. Sometimes they become immobile. Sometimes they become aggressive. Sometimes they resist to be cared for. So you will also assess. So these are the behaviors normally that help us to assess this patient. So you cannot say Agakod Kuluma or his dementia cannot talk with us. No, we can do something to assess those patients. So then how best we can provide assessment and treatment. I will just rush through these questions that may help us to assess and treat this patient. The first thing that you need to understand is that you need to ask yourself is there a reason for the patient to be experiencing pain? That's the question I need to ask myself. So what I'm going to do, the answer I will get from the review of the patient's diagnosis. We know these progressive conditions, they keep on going forward and progress, or there's a wound that is so septic. There are many different things. So is there any reason for this patient to experience pain? So I will review the patient's diagnosis. What is the patient suffering from? Arthritis. So what is happening? How advanced is the arthritis? So you will discover that this patient now needs cervical cancer stage 4. The patient is on radiation, is on chemo, all those things, they help you to make the assumption that no, this patient can experience pain. Was the patient previously treated for pain? If so, what regime was effective? So if the patient has been on pain before, pain medication, what medication was used, how effective it was? Most of the time, you will get this information from pain assessment documentations. You will get this information from the pre-auxiliary patient reporter or the caregivers or relatives. They will tell you, and you reference based on documentation. That's why we are saying in pain assessment, documentation is key. So for this patient, you rely on that information. You ask yourself that question. Another question is, how does the patient usually act when she is in pain? If in pain, what normally happens, what the patient does, What is the family or significant other interpretation of the patient's behavior? What are they saying? Do they feel the patient is in pain? Why do they feel that way? Those questions are key. Some will say, I know he's confused. Some will say we are suspecting Gogo is in pain, and they will tell you why they are suspecting that. And then you look at the patient, and then you will be able to come up with, no, let's try to relieve the pain there. Try to obtain feedback from the patient. This one is very key. Patient communicate with us. Unfortunately, we fail to accommodate them in our communication in language forms. So they will use bodily communication. If you ask the patient, do you have pain? They will nod their head. They will squeeze your head if they are unable to speak or even nod their head. If you hold their hand, they will squeeze it. They will move their eyes. They will raise their legs. They will hold up fingers to signal the presence of pain. So that's why we said last time, the 5-finger assessment tool is very key with the patient, especially when the patient is still cognitive. When the patient now is impaired or unable to talk, they will be able to relate with what you are saying. So always seek the feedback, establish a good rapport with your non-verbal or cognitive impaired patient. They will be able to tell you. You will even tell them, if you feel the pain, squeeze my hand. If you feel the pain, you will establish a good communication, a meta communication between you and so you get the feedback. If appropriate, overwriting materials or pain intensity charts that the patient can use or point to. I once had a patient who had brain tumor who was unable to talk because of it, and the patient was experiencing pain. Unfortunately, the patient couldn't even hold the pain. So first of all, we have to learn now how to communicate with the patient. But then the issue also is not your head, because the patient can hear what I'm saying, but cannot relate to it. They don't understand. But there are those who can write. Allow them to write, give them the two, the longer faces with you. If you have explained the numeric to them, they will understand. If you have used the 5-finger very well, so they will be able to share the intensity of the scale. So don't jump them and say they cannot hear you or what. Always the proxy is there, and then also get their feedback from them. If there is a possible reason for signs of acute pain, treat analgesia or other relief measures. So there are possible reasons for signs of, for example, a procedure, wound dressing, right? I will do a wound dressing, and after I've done it, go screaming. That's a sign, no, I need to correct this acute pain. The patient is fallen, or is after a bath, or is after a change of position. You see, those are things. So we need to then, yeah. Management has opened the microphone there. I don't know if we can mute. And then, if a pharmacological or non-pharmacological intervention result is modifying pain behavior, continue the treatment, right? You remember I said, ask why the patient has been using. If they have been using pharmacological, it was changing the behavior, it was effective, reinforce it. If it's a non-pharmacological intervention, reinforce it as long as it has positive outcome. If the pain behavior is present, rule out potential cause of the behavior, right? Because this patient has different issues. Sometimes they mention the confusion has been deepened. You know, maybe the patient is now beginning to have hallucination, is approaching end of life. So there are many things. So you need to rule out other causes of the behavior. Then you can now choose the appropriate intervention. So you need to understand that, oh, this patient is like this. This might be a confusion. This might be something else. So explain the interventions to the patient. Even if it's cognitively or verbally unable to communicate, please ensure you explain the intervention to the family and the significant others. That one will help us to provide treatment and okay. Maybe Before I'm coming closer to finishing, these are the tools that we have. We have the flat scale, we know it. We look at the face, the leg, the activity, the crying, as we have presented in the last session, and then we calculate up to 10, and then we get the intensity of the score. We also have the pain assessment tool in confused older adults, where we are looking at the quivering, the guarding, the grounding, the frowning, the grimacing, and clenching of joints. So those also, they will tell us how much pain the patient is feeling. There is this other tool that we have for patients who are cognitively impaired or verbally unable to communicate. Is the pain assessment. You ask the caregiver. Remember, we said pain is subjective. Even if you are going to ask the caregiver, don't forget to establish the communication between you and the patient, where you will establish a way to say, is pain or not? Is it severe or not? So you establish those using the other things we have talked about, the 5 finger, the conga faces, the numeric and other ones. So this one is very important for the nurse or healthcare worker and the family members to know the patient's usual behavior and patterns so they can be able to detect the pain. So we need to do that. So those are the tools that we have. So you need to know exactly which tool I'm going to use and with who. So there are implications that come with implications that for pain treatment, the assessment of this patient. So one, pain assessment, a challenge to clinician. This is a real challenge. One patient pain is difficult to assess with this patient, but should not pose a barrier to optimal pain management, right? It's a challenge, but not a barrier. It must not stop us. Number two, the best approach to assess pain here is to assume that the underlying disease is still painful and continue in pain intervention based on analgesic history. That's the only best approach you can take. Is that this patient has an underlying condition that is painful, and I need to continue with the analgesic based on the history, and then improve looking at if there's a change in behavior. They should be empirically treated for pain, you know? If there is a persisting pain or evidence that any individual is in a similar condition would express pain, so you need to use evidence-based. So you need to do that one. And otherwise you will fail to manage it. And then the last one, the major one also, is that palliative care measures should be considered in those with behavior changes potentially related to pain. So you need to consider the other palliative care measures. These maybe are the last shots that we may give you on pain assessment and total pain assessment. Overall, from the start, we started the pain assessment. As we are going to prepare ourselves to go for pain management, we need to remember the summary of all what we have been discussing in the previous presentation is that pain is a multifactorial and affects the whole person, family, and caregiver. So when we are doing your assessment, remember total pain concept. It's a multifactorial and affects the person and the family as a whole. Everybody, once there's a pain is a holistic thing, it's multifactorial. Multiple barriers to pain exist. So when we are approaching pain assessment, be aware of the person you're assessing and be cautious of barriers, potential barriers, and you need to eliminate them together with the family and the patient in collaboration as a teamwork. We need to deal with that one. And then another thing that we need to understand with pain assessment is that patients should be screened for pain in all care settings, OPD, admission in the ward, you know, every space where a patient comes in, whether it's OPD, it's public health, it's palliative care, it's theater, wherever a patient will be in contact with a healthcare worker. We are even at home, if you are going to be taken for home, wherever you will contact with a patient for care, screening, not because the patient has verbalized it, but screening like you are doing with cancer screening. So if the patient pain is a pandemic too, So we are, normally when I'm doing presentation, I usually say, even us workers, we are sick. If pain or discomfort is reported, a comprehensive assessment should be performed. Then there's a difference between screening, but then if then I am getting a report of pain, I need to provide a comprehensive assessment. Then this comprehensive assessment should be conducted on regular intervals, right? Whenever there's a change in pain, right? I don't wait for the month to finish. That I've given you movement for 30 days, I will wait for 30 days to elapse. No, I need to, when there's change, I need to assess. After any modification in pain management, right? I've moved from step 1 to step 2, I have to check. I've moved from step 2 to step 1, I have to check. Do assessment, comprehensive. Reassess pain intensity. The assessment of pain intensity should be at least 1 hour after the intervention. If you have a patient in your facility presenting with severe pain, just coming with severe pain, you are getting patient in, or you are getting diet, you are injecting that patient. After an hour, do some reassessment. How will the intervention be effective? So the patient self-report of pain is the gold standard. Remember, patient report of pain is the gold standard. So you need to get it from the patient. Then we need to evaluate pain assessment instruments used in our case settings. I believe now we have all tried to access our pain instruments, especially in the country we have the numeric ones. So check them if they are useful for your patient. And then we even have to go to the bias connecting MS studies. So that's what I can say with our patient. Not one tool works for every patient, right? So you need to get the evidence. Try to use the tools, get to know which population works best to which one for your facility, and then get the ones that are culturally sensitive tools, you know, so that the way you assess a man and a woman in this country is different. So you need to understand your patient differ, but patient report is key. That's what I can share in summary for pain assessment for the non-verbal and in terms of the pain in total assessment. So we have covered pain assessment as a whole. Now, so we are looking forward then to move from pain assessment to now intervening. Thank you.
Thank you, Mr. Masham, for the presentation. Thank you for unpacking how we can best assess pain for our non-verbal and cognitively impaired patients. Some of the main things that I was able to pick was that we mostly use observation more than anything as we deal with these clients, because it has been mentioned that we need to observe the patient's behaviors that indicate pain. And from those behaviors, we also need to communicate with the proxy to get information about how they usually, how the patient usually acts when they're in pain, so that we can be able to know and understand the kind of behaviors that they usually present when they are in pain. And that we should also be mindful of their facial expressions, their body movements, and their mental status changes, because they can also be an indication of the presence of pain. So in a situation where we get to know how the patient usually acts in pain, it helps us to be able to rule out other potential causes of that behavior and apply appropriate interventions. So at this point, colleagues, I would open this time for any questions or comments or additions based on the assessment for nonverbal and cognitively impaired patients. You can raise your hand or unmute, and you can also use the chat box to ask questions, make comments or additions. Do you have any questions or comments, colleagues, before we move forward to our case presentation for the day? Please show by the raise of hand or by using the chat box. I will take the silence as an indication that we have all understood everything that was presented about cognitively impaired and nonverbal clients in terms of pain assessment. But if we are leaving you out, feel free to use the chat box to ask any question or make any comment or any additions about your experiences with cognitively impaired or nonverbal clients. At this point, I would like to give the opportunity to the Manzini Government Hospital to give us today's case presentation.
Good afternoon, colleagues. This is Eswatini who will be presenting this. I've got a 45-year-old male patient who had a Kaposi's sarcoma in a nodule stage. So this patient didn't have any pain on this. Fine, he first went up to Mbabane for treatment. He was on the first line and also on the second line without any, it was not effective up until he was transferred to Manzini. Fine, we started him on the second line, but we noted that the main problem was poor adherence on art. When we tried to ask him about art, he was not, he didn't come out fairly. Instead, we found that there were no traceable records. So he was moving from this facility to that one. So we then he was started on art with a good effect because the second line was so effective. Then his chief complaint, he had a septic on, the lesions were very septic. It was even oozing pus and was even unable to mobilize. He was on a wheelchair. Then his social life, he was married, but he separated with the wife, and he said he was self-employed, but because he was unable to move around, he was even unable to work for himself. It means he had a challenge with getting something like money, I would say. He was only helped by the siblings. Okay, since he was unable to adhere with the medication, he was lucky enough because each and every week he was taken by the sisters. This week he stays with this sister, then the following week taken by the other one. So they were very supportive to him. We tried to speak to the siblings that they must try to do DOT, and with the results we could see that they were very supportive on him. The main problem with him, he was thinking that it was witchcraft, umkhwebo in Siswati. That was the thing that was causing him to have these lesions. But after taking the medication, there was a great change. Fine, even before he was not complaining of pain. Then as he started to be on the medication, taking art well, he was able to come out of his wheelchair. He was able to do anything at home. Okay, fine. The medication that he was given, the second line, which we started, it was paclitaxel. The paclitaxel and atrimicin didn't work for him. It means that we only started him on a plimicin or vincristine. I'm sorry. Or with the social history, work status, it's self-employed, education, tertiary, marital status, separated with the wife. Then with the social economic class, we classed him in the middle class. Lifestyle habits, our patient was smoking and alcohol. He said he used to finish something like 5, 6 per day. Yes. Okay, with the advanced directive, advanced care planning or directives. Okay, he has been, he has started to okay, the lesions were much better. Okay, advance decision to refuse treatment. No. Healthcare, healthcare proxy. No. Mental capacity assessed. Yes. Okay, the review on the vital signs. EPP was 104 on 77, pulse 85 beats per minute, respirations 18, SpO2 95%. Pain score, it's a 0. Eco functional score, it's a 0, 0 to 4. Or eco functional score, it's 1 from eco 2. Okay, with the palliative care case presentation form on the ranks, symptoms 0 on pain, dyspnea 0, anxiety 1, agitation 1, depression 1, drowsiness or fatigue 0, nausea or vomiting 0, anorexia 0, constipation 0, dry mouth 0, poor mobility 2. Focus investigation, we only did HB, which was 8.9. Patient was then transferred 2 units. Okay, with the CT scan is still pending. We didn't get the results. Then further plan is to continue adherence counseling, supportive care, discussing management plan and prognosis, continue chemotherapy, family, especially the brother, to continue directly observing at intake, follow-up calls. Thank you so much, colleagues.
Thank you, Amy, and thank you, Manzili Government Hospital, for the case presentation. I think it is clear that you have taken good care of this patient. At this moment, colleagues, we can maybe make suggestions or recommendations to support the Manzini government hospital on how they can best help their client as it has been presented. If anyone has any questions or recommendations on how the clients can be better taken care of, please unmute yourself or you can use the chat box. I think there's a comment from my colleague from Nico team.
Good evening, Manzini Government Hospital. My only comment would be to sort of praise in the way the client was managed, because it seems at the start of your presentation that the main problem was the treatment, was the query treatment failure. So I saw that in your further plan of management, you identified a person who is close to the patient who is going to help with the taking of art, which is what I would like to comment on your part. Thank you.
Thank you, Nonverbal. Do we have any other comments or questions? Nonverbal is applauding the Manzini Government Hospital team for how they've managed the client. Do we have any other comments or questions?
My question, this is an interesting case, especially it's a man. So in our country, we challenge with men, in fact, in terms of accessing or seeking medical care. So maybe my interest is on the issue of the divorce or the separation of the wife. Did the man narrated and the events that led to such activity or a scenario? What was the cause of the divorce? And then another issue is the issue that I'm aware that now the patient is self-employed, and then there are siblings who are helping. I've seen that the patient now is staying at home, and then are they still supporting the patient? How the patient view himself now that he's a dependent. And then another one that is so interesting is the issue that the patient is saying he was bewitched. My interest is that has the patient accepted the diagnosis? Does the patient now understand what he or he has? I don't know. What is the patient information in terms of that? Maybe I'm seeing the improvement, but I'm interested to know this. Maybe it can help others too to know, to reach where you are. This is where you've gone.
Good afternoon, Tim.
Good afternoon.
Yeah, sorry for joining you late. So I don't know whether I'll do justice here, but it's Tandaziles Milani now. Yes, I think they covered much of what actually transpired until we got to where we are. So responding to the question of the divorce, it may be very tricky getting a straight or an honest answer with this one, you know, man, like you were saying. So the one thing that he mentioned is that since he got sick, then the wife decided to leave. So that's the one side of the story that we have. We don't know what actually transpired, but that's what we're going with currently. And yes, the client is no longer able to fend for himself currently. He's supposed to be coming for another review next week, but he even mentioned that he will only rely on a lift that he will get on a Friday. So it's basically depending on the siblings. They are doing a great job. The brother is actually down at Lota with him. So they are supporting him financially and otherwise. They were doing a great job. And in terms of taking care of him, doing the dot, because initially we had challenges. Like when he came here, we didn't even have any traceable records of him being on art. We only got it from them that he's on art. But when we digged deep, we discovered that even there is issues with the art. That's why we felt like, no, let us strengthen art intake. That's why we started, actually, even before we started with the chemo. Because when he came here, he had already taken the first line at Mbabane, and apparently it didn't yield much results. He took paclitaxel, I'm not sure how many cycles. Then he took adriamycin, bleomycin, vincristine as second body. Here we had to remove the adriamycin because we can only give adriamycin to a certain level. Then we continued with bleomycin, vincristine, but that was only after he had restarted art. So now, currently our client is doing quite well. The lesions are going away. Sepsis is clearing. He's even able to put on his pair of trousers, the long ones. Yet when he came here, he was bound on a wheelchair. He wouldn't even use his trousers. Most of the time he was covering himself with a towel. He would just put shorts, cover himself with a towel. So we are seeing so much improvement. However, we had to sit the client down together with the family, explain to them, okay, this is what transpired. We had to make them understand that art alone is enough to actually deal with the KS. But considering the stage at which he is, then we have to continue with the art, we have to continue with the chemo as well. So he is appreciative of the fact that no, it is no longer witchcraft now, because he is seeing a difference. However, we still have to have more sessions because there is issue of lymph edema now. So in as much as the nodules may go away, but we may still have a challenge with the lymph edema. So the swelling may still be there for quite longer. So we still have to have ongoing sessions with them. So for him, we prefer seeing him work together with the brother, because we cannot take it for granted and say now he is adherent to treatment. I'm not sure if I answered your questions, Mr. Mahlangu.
Thank you, Thandazile, for responding to the question. I think we have all been enlightened on some of the concerns that we're having about the client's spirituality. I don't know if there's any other questions or comments or recommendations from other colleagues. I'm wondering, since the client is at home now, if you've been able to link the client with the home-based care services?
Okay, yes, the client is home now. Okay, we actually, because we usually make follow-up calls. So we only discovered just recently, we called them day before yesterday. So that's when we discovered. Otherwise, all along we knew that he was staying with the sisters. So they were changing like on a weekly basis. So now he is home with the brother. We haven't linked him to home-based care for now. But we are hoping to be seeing the client, because also we need to discuss that with him, get consent from him, and also link him to home-based. We are hoping to be seeing the client. He actually asked to come on Friday, so we are hoping to see him on Friday.
Okay. Okay.
Yes.
Thank you. Do we have any questions or comments before we give our recommendations?
My question is how do you control the sepsis? Do you have anything for home and hospital intervention that you share with the patient that can control the issue of sepsis, like wound care at home, and what are you using? Because sometimes we meet in the day. Maybe you can share how, or it was the treatment of the underlying cause that has dealt with the wound.
Okay. Initially, when he came, yes, the lesions were septic. So we were doing wound dressings on every other day. So it was possible because he was still staying around Manzini at that time. So now with the treatment, because like we said, he has been doing quite well with the arts and the chemo, because he's on his 6th cycle already with the chemo as well. So he's doing well, and that is as evidenced by the like I mentioned the other time. I said there is the sepsis is clearing. He's doing quite well. So I think what they're doing now, they are just doing well, I cannot call them cannot call them sit baths now. What do we call them? But they use your usual warm water and salt. So they just immerse their feet in warm water and salt. Come on. Yes, they just immerse their foot in warm water and salt. And he's doing fine. He just clear.
Sit back, thank you. No, thank you.
Thank you, Thandazile. At this point, can Mr. Matang give us the recommendations for the case?
Okay. Thank you so much. This is an interesting case, when I don't know where are we going to get an angel to help us with men, because you can tell that he has reached this stage because of reluctance to take medication. But what draws my mind to this patient, I was happy that he's saying he's not experiencing pain. Men, they will say they're not. But what draws my attention to this patient, I'm happy that now he is okay and he's getting more support. It was just that to share, but we'll still to cover such an aspect in our near future. I will share a few things that they are happening. We have already shared the information concerning the problems that are there with the patient, looking at a 45-year-old man with the treatment failure and, Kaposi sarcoma going up and down with those history of spiritual problems. I just want to share some things that maybe we can look around in the future, or else if anyone meets such a patient, things that can help you also. What I saw here, I saw a patient who is spiritually and socially, psychologically experiencing pain. It is not easy for a man to move around the street with septic wounds. It's not easy. I don't know how women bear that so much pain, but for a man, it becomes so difficult. And I'm so happy that the great work you've done, because now he's beginning to trust you and coming closer, because he's seeing that you are coming close. But these are the things maybe factors that influence the way which patients and families cope with their illness. I've got that he said that once I've got this diagnosis or this condition, my wife deserted me or left me. He might be not telling the truth. Maybe it was the issue of infidelity, and then the wife decided that I want to leave you. But I just to share with you some factors that usually influence the patients and the families to cope with the illness, and these things must be considered maybe in the assessment of these patients. The first thing that we need to understand always when we are meeting such patients is that we need to get the history of the illness and their understanding of what is happening, and including their emotional and psychological response to the condition. It helps us to heal them for a long time, other than to heal them for now. We find that if the family is in the patient, then you get the history of the illnesses, and then their understanding. I'm happy that you was able to say, you will find that there was anger, there are those things. So you need to understand, get their understanding and the history of the, how did you come to get this condition? What has happened? You know, how the illness is affecting the person's ability to carry out their role. For example, as a parent, as a partner, as a lover, and a breadwinner. If this man is saying I'm divorced because I've developed KS, to me, it tells me a lot of things. There's a woman here who have lost an intimate partner because of a certain activity. So we need to understand how has the illness contributed to that. Sometimes there are many women, I don't know if this woman will move forward if the man he will get married to another man. And if the other man will behave the same, you will find that we have a psychologically affected or psychologically ill patient who is moving around this. So we need to also get that history. How is the illness affecting the patient, you know? Also, we need to also look at around the issue of the family history, you know, getting the family history. In this family history, I would encourage, you know, normally it's the social workers who are good in doing this, but also as a healthcare worker. These sessions, you can break down such history taking into sessions. For example, another day, I want us to talk about your illness, what you understand, then you talk. Another day, I want us to talk about how this illness is affecting your role as a man, as a partner, as a father, as a brother, you know. It's a session on its own, you discuss, so that the patient can spill up this pain. And then another day, you are also healing this patient psychologically and socially. You also do this thing we call that family tree, genogram. This one will help you both to understand the relationships for use as a therapeutic tool in helping the patient talk about their issues. So if you allow patients to talk about their family, that family will be able to discover, no, it was not that the Kaposi sarcoma. The relationship was long ago finished. It's when you discover, when you're doing the genogram thing, you discover that it's a generational problem here. We are not dealing with Kaposis today, but we are dealing with generational problem here. That has been there for a long time. So that one is very key. So you need to also tell the day when you are going to do the genogram, get to know the family standing, and then there's a lot that you will find there that will also be therapeutic in dealing with these patient issues, and it will help them to cope with issues. So you also look at life stresses, you know. You need to get some there. I want us today to talk about your life stressor. What is happening about, maybe for example, financial discussion. Today I want us to talk about money, jobs, or I want to talk about the major stresses that you have. What are your fears today? What stresses you the most? For example, with regards to money, jobs, housing, children, resources of support, and how the person has previously coped with stressful situation in life. It will help you to know, okay, this person has a poor strengths and weaknesses, and even if he's post this physical problem, we don't want to see this patient coming back because he's fighting life stresses, you know. Also, we want to talk about hopes and fears. This one is very key. You know, they have fears, they have hopes, they have a lot of things. So we need to know what is the worst thing that can happen and what are the plans for that. For example, how do you initiate that with a patient? You know, today I want us to talk about the future. I want us to talk about hope. I want us to talk about what we fear the most today. So you arrange your sessions into small chunks because patients don't want to bombard them, but want to get a lot out of them and want to make them cope very well. So you look at that. To the plan, what losses and disappointment is okay in your life, you know? He will tell you, I've lost the business, I've lost the wife, I've lost children, I've lost friends, and then that's where you are able to heal them. So you give them the time to discuss about what their fears, their They are unfinished businesses, you help them. And what do they still wish to accomplish? It helps them to move forward. Even this one with art, if this patient can now identify the purpose in life, you will find that now he will associate taking art or adhering to art with the business he wants to finish. So you have to give them that, what is the hope? You will find that he's not taking art, he's hopeless soul. He feels like it's nothing anymore. And then he's prone to relapse, because once he is out of the health system in terms of physical care, he will not have a reason why I must continue living. And another key thing is that I would encourage that in such patients also, I've seen a patient with spiritual distress in this patient, He's blaming witchcraft, he's doing those things, he's not willing to take medication because there are many superstitions in his mind. The other thing we need to consider, in most of our patients, especially when we're taking care of them, even in facilities like yours, is the spiritual assessment. There's another model we can use, the hope one. That's very straight. So we look at the sources of hope, strength, we look at organization, we look at practices, we look at the effects on what the patient thinks can be supported on. Because even the issue of superstition and stuff, you will find that he will default back to what he found hope in. So we need to look at those things. Now we are seeing this patient going for window shopping. So he's going for window shopping from one person to the next. He doesn't believe this. Differentiate different beliefs and misconceptions, The facility believes this is capacity, he believes in this. He believes in witchcraft, and then he needs in traditional intervention, The spiritual medical practice needs to be also verified. So how do you then get to know people express spiritual distresses? They fear about the future, about dying, what happens after death. They will tell you something like that. The loss of identity roles. What a person has said, I've lost identity or a role. That one is also a sign that there is spiritual distress, especially parenthood, work, and other stuff. Helplessness, loss of control. For example, have you ever felt you have lost control of your condition? Then you will get to know this patient is undergoing spiritual distress or not. Anxiety, I've saw that the patient is mild anxiety and depression. What could be the cause of anxiety? It's when we know, do you have any anxiety about your relationships, about your body image, about sexuality issues? You know most. This is a man, so you need to also understand that one. That's why at some point in time, we need to sit down with them and talk about sexuality. Today I want us to talk about sexuality. What do you understand? Suffering excessively from physical symptoms, especially pain. The patient will also sometimes express issues of anger, guilt, and shame. Once they've shown that, have you ever felt guilt or ashamed? Then you will understand, then you are opening that case for spiritual assessment. Hopelessness, despair, feeling unloved, when they say that, then you mean you are exploring the spirituality issue, then you are able to get it. While they are telling all those things, you get to help them. Another thing I would say that spirituality is that exploring the meaning or the purpose in their life. Once they've heard that, it will be used as a bargain for adhering even to the treatment. Also, sometimes when you understand the issue of breaking the religious and cultural ties, these people have these practices that they want to do, and sometimes they have a desire to reconnect with their supernatural being and they need some support, and then you are helping them. But when we are doing a spiritual assessment, be ready that sometimes you will not get what you are looking for. And it's okay not to get what you want to get, you expected to get. And sometimes you don't even need to say a lot, just to be present for them and ask them, and then they feel that there's somebody to help them closer. So it's also that connection is so powerful. So I'm happy that the brothers have never neglected this man. So the fact that we are there, and sometimes we don't need to be afraid to ask simple questions about fears, losses, and feelings. We need to ask them about the future and the sense of control. We need to ask about past regrets, not the current one. And the past regrets that the patient has had. Spiritual beliefs and religious need, and then offer the supportive care that could be offered maybe chaplain, then depending on the level of spiritual distress that you see, then you can require for that one. So I will say that one. So there are basic things that we need to understand that we need to provide an environment for caring. Always we continue to give that give value in the role. Attend to the patient's needs. Ask yourself always when you are meeting a patient, why am I being told whatever the patient is telling me, and why it's me now? And sometimes you have to give yourself time to listen to them. And then you will get those tears of anger and those, and get to know their story, what they are saying. Assess items of past and present future. Reassure the patient, always give them that you are going to give them the best that you can, and you will help them where possible. And wherever they need some finished businesses, talk with them and get those people who will be there to support them. I'm happy that he has family that is caring for them. And the reviewing of life, every time you say that, what are they reviewing, what are they saying? And then you arrange for any spiritual support. I would say to that, but lastly, it's not easy. Let's not forget ourselves. Let's remember ourselves in this case. We are facing such issues every day, but let's not forget ourselves. And we are always vulnerable to such a situation. So we need to also take care of ourselves. Not forgetting the issues of culture and upbringing. In the country, we are having different people. We need to also consider those things. I would say for this patient, continue focusing on the physical, but set those sessions that will help the patient for permanently attending to this spiritual issue, because we don't want them to disturb the patient again. Help the patient to rediscover himself after all these scars of these new tools and stuff, so they can find the meaning even to go forward. Even if the couples can relax and come up with better, but let the patient find meaning out of this. So those are the counseling sessions you need to go through and have to discuss this issue. Now that you're divorced, do you see yourself married again? You see, we are able to see the confidence of the patient. Now that you are like those are the sessions, you cannot discuss all of them in one day, but prepare those sessions. So I'm saying in short, don't quickly discharge it, take some time. When it's coming for chemo, set the milestones. Today I want us to discuss this. When it's coming for certain session today, I want us to discuss this. That's when you also discover, do you need a follow-up social worker or do you need a family meeting? It's when the patient now is disclosing things and is becoming to trust us as healthcare workers, not viewing us as ladies and men, but is viewing us as people who have come to help him find himself again and be strong again. Thank you so much, Manzini Hospital. This is an inspirational case. So he doesn't need a lot of drugs. He needs some psychological, spiritual, emotional, social care. Thank you.
Thank you, Mr. Masango, for the recommendations and the feedback to the Manzini Hospital team. I believe we have all picked certain things that are very applicable in our line of work as we take care of our patients. There is a link that we are going to share on chat box. Please click that link and give us feedback. Thank you for joining us in this session. We are hoping that it was very informative and helpful to all of us. But if you feel like you've missed out on previous sessions, you can go to our YouTube channel and be able to watch all the other sessions that we have had from the beginning of our ECO sessions. Our next ECO session will be on the 16th of November, where I believe we will be looking at, the management of pain. We'll most likely start with the pharmacological management of pain. So thank you, colleagues. Do not forget to click the feedback link. Have a lovely day.
Thank you, Manzini Hospital. Never give up on us. We have learned a lot today. Bye-bye, guys.
Thank you everyone for joining in. We will share the feedback link later. Right now, there is some issue with it.
Thank you.
Thank you.
Let's meet on the 16th of November.
Bye-bye. Thank you.
Thank you.
Bye.